Hi everyone. Uh, Thank you for inviting me to participate in the Exam Focus 2024. Now we discuss regarding the topic of tooth eruption. So under this chapter, in the following session, we are going to discuss briefly regarding the definition of tooth eruption, the theories of tooth eruption, the physiologic tooth movements, and also certain clinical considerations regarding tooth eruption. These are some of the previously asked questions in the KUHS exam for first BDS. One or two essay questions and some short essay questions like theories of eruption and its clinical consideration related to eruption, mechanism of tooth eruption, then the phases of eruptive tooth movement, root growth theory, ligament traction theory, phases of pre-eruptive and eruptive tooth movements, and also this gubernacular canal and gubernacular cord. So first of all, we begin with the definition of tooth eruption. So the definition of tooth eruption is very important because whichever question is there from this topic of eruption, you can write down this definition. And also it is very important viva question. So how do you define tooth eruption? Tooth eruption is defined as the axial or occlusal movement of the tooth from its developmental position within the jawbone to its functional position in the occlusal plane. So from the definition itself, you can see that the process of tooth eruption is a dynamic one. It begins from the initial formative stages of the tooth within the jawbone, and it continues through various phases. The tooth erupts into the oral cavity, and it moves till it meets its antagonistic tooth in the opposite arch or in the occlusal plane, and even after it continues in the post-eruptive phase. For teeth to become functional, considerable movement is required to bring them into occlusal plane. This complex movement made by teeth may be described as pre-eruptive tooth movement, eruptive tooth movement, and post-eruptive tooth movement. This pre-eruptive tooth movement starts from the time of formation of the tooth within the jaw bones till the completion of the crown portion. Whereas eruptive tooth movement begins after the crown completion and from the stage of formation of the root portion, and the post-eruptive tooth movement is happening only after the eruption of the tooth in the oral cavity. Pre-eruptive tooth movements. This movement is made by deciduous and permanent tooth germs within the tissues of the jaw before they begin to erupt. It constitutes the movements positioning the tooth and its crypt within the jaws preparatory to tooth eruption. It is actually linked to the jaw growth. Here, tooth germ makes extensive movements within the developing and growing jaw bones. So in pre-eruptive phase, initially the developing tooth germs are smaller in size. So there will be a lot of space in between. Later, as they increase in size, there exists some amount of crowding, and it has to be relieved through its movement in mesial and distal direction. So during the formation of the succedaneous tooth, along with the deciduous teeth in the anterior region, the permanent teeth develop lingual to the incisal level of the primary anterior teeth. So initially, the incisal level of both the deciduous anteriors and its succedaneous teeth are at the same level. And later, as the primary teeth erupt, the permanent crowns are positioned lingual to the apical third of the roots of the primary tooth. Also, in case of this premolar tooth germs, which are initially situated on the lingual aspect of the crown of deciduous molars, move to a position between the roots of this deciduous, 'deciduous' 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 ' Whereas for the non-succedaneous teeth, in case of permanent molars, the maxillary molars initially they develop within the tuberosity region, and its occlusal plane is faced distally. Later on, as jaw growth continues, it will be repositioned through its movement and facing the occlusal surface is facing towards the occlusal surface. In case of mandibular molars, they are beginning its development within the ramus region, and its occlusal surface is faced mesially, and later on it also moves to occupy its position, and the occlusal surface it's facing the occlusal plane. So there are basically two types of movement in the pre-eruptive phase. One is the total bodily movement of the tooth germ, and second is an eccentric movement. Here, one part of the developing tooth germ remains fixed, whether the other portion continues to grow. So it will lead to a change in the center of the tooth germ. So this is known as the eccentric movement. So we have total bodily movement and an eccentric movement happening in the pre-eruptive phase. And histologically, there will be bone remodeling and areas of bone resorption and bone deposition within the crypt walls. Next is regarding the eruptive tooth movement. It is made by the tooth to move from its position within the jaw bones to its functional position in the occlusion. It has an intraosseous and extraosseous component. So in the eruptive phase, various changes are happening, like formation of roots, the periodontal ligament, and the dentogingival junction. And with the onset of eruptive tooth movement, there is cessation of resorption and bone deposition occurs on the crypt wall. So here the reduced enamel epithelium plays a major role. They proliferate and seem to induce atrophy or lysis of the connective tissue, separating the reduced enamel epithelium from the oral epithelium, so that the reduced enamel epithelium and oral epithelium can fuse together, and it will create a pathway for eruption. These reduced enamel epithelial cells may elaborate certain enzymes that dissolves the connective tissue in between the reduced enamel epithelium and oral epithelium. And it has been proved that premature degeneration of reduced enamel epithelium can prevent or cause a delay in eruption of tooth. So in the eruptive phase, the reduced enamel epithelium is having a major role. So what is gubernacular cord and gubernacular canal? It's an additional anatomic feature possessed by mostly the succedaneous permanent teeth. Here the permanent tooth germ situated apical to the deciduous predecessors is entirely enclosed by bone except for a small canal, and this inverted triangular shaped canal is known as the gubernacular canal, and it is filled with connective tissue, and it is having the remnants of dental lamina, and this connective tissue mass situated in this gubernacular canal is known as the gubernacular cord. Here you can see the area filled with the remnants of dental lamina in the connective tissue, that is the gubernacular cord. It is situated in a bony crypt that is known as the gubernacular canal, and this gubernacular cord has a function in guiding the permanent tooth as it erupts. So you can see the gubernacular canals lingual to the deciduous teeth in dried skull bones. Next is the post-eruptive tooth movement. It is for maintaining the position of the erupted teeth in occlusion while the jaws continue to grow, and also to compensate for occlusal and proximal tooth wear. So this is a movement to accommodate and compensate for the growth of the jaw bones and also the incisal and occlusal tooth wearing. Post-eruptive tooth movement falls into three groupings. First one is for maintaining position of teeth during vertical growth of jaws. And second is for compensating the incisal or occlusal tooth wear. And third is for compensating the interproximal tooth wear. An increase in vertical dimension of jawbone is accompanied by repositioning the teeth. So here you can see at 6 years of age, a certain vertical dimension of mandible is mentioned there. And the same individual at 12 years of age, the height has been increased. But the tooth size once formed cannot be changed. So the teeth has to be repositioned according to the increase in vertical dimension of the jaw bones. And also the post-eruptive tooth movements are happening in order to compensate for the occlusal or incisal wear, and also in order to compensate the proximal tooth wear. So the first two events of post-eruptive movement is actually happening in a vertical direction or axial direction. The one which is there to accommodate along with the increase in height of the bone, and also the movement in order to compensate for the incisal or occlusal wear. It is happening in axial direction or vertical direction, whereas the movement to compensate for the proximal tooth wear is happening mostly in a mesial direction. So thereby there will be a decrease in the arch length. So this post-eruptive tooth movement, which takes place in axial and mesial direction, historically there will be selective deposition and resorption of bone on the socket wall. Now we move on to the theories of tooth eruption. We have various theories proposed regarding the tooth eruption. We have the bone remodeling theory, vascular pressure theory, root growth theory, ligament traction theory, pulp growth theory, neuromuscular theory, and dental follicle theory. First is regarding the bone remodeling theory. So the inherent growth pattern of mandible and maxilla move teeth by selective deposition and resorption of bone. So at the onset of tooth eruption, bone is resorbed at the base of socket, and this is followed by deposition of bone on the socket floor. So this is what is regarding the bone remodeling theory. Here there is selective deposition and resorption of bone, and it will bring out the process of tooth eruption. That is what is proposed in bone remodeling theory. But the measurements using bone markers have shown that the deposition of bone is an infilling after the tooth has moved. That is, it is an effect and not a cause for tooth eruption. So this point actually negates the concept of bone remodeling in tooth eruption. So next is root growth theory. So it is suggested that increase in length of the forming root itself provides the eruptive force by pushing against a structure termed as the cushion hammock ligament. Cushion hammock ligament. It is a sling passing from one end of the socket under the root apex to the opposite wall of the socket. So the proponents of this theory believe that the cushion hammock ligament converts the downward thrust of growing root into an eruptive force. It's also known as pulp delineating membrane. So pitfalls of root growth theory. Cushion hammock ligament has been shown to be an optical artifact and is actually a pulp delineating membrane with no connection to the socket wall. Eruptive tooth movements occur in teeth whose apices have closed and where all cell proliferation has ended. Some teeth move more distance than the length of the roots. For example, the upper canine. The rootless teeth also erupt. It has been proved experimentally by resecting their roots. When the deciduous tooth is extracted, the succedaneous tooth erupts rapidly even if the root is only half formed. And also the natal and neonatal tooth erupt with incompletely formed roots. So these are the points against this root growth theory of eruption. So next is vascular pressure theory. So as per this theory, the eruptive force is provided by the pressure in the blood vessels within the tooth and at the apical region. Measurements of tissue fluid pressure below and above erupting teeth has shown a pressure difference of 15 millimeters of mercury, which is more than enough for eruption. So this is what is proposed in vascular pressure theory. So this theory also suggests that experimental interference with mechanisms controlling the caliber of blood vessels affects tooth eruption. The cervical sympathectomy and stimulation of cervical sympathetic trunk also affects eruption. But the points against this theory are pulpless tooth also erupt, and the use of hypotensive drugs have no effect on the eruption rates. And experiments undertaken with the continuously erupting rodent incisor are indicative of some other mechanisms in tooth eruption. Even after removal of the proliferating dental organ and dental papilla of the continuously growing lower incisor of rodents, the tooth continued to erupt at a normal rate. The fact that the only unoperated dental tissue remaining in this experiment was the dental follicle periodontal ligament complex. It suggests that this complex actually provides the force for tooth eruption, and thereby a well accepted theory of tooth eruption, that is ligament traction theory, was proposed. So according to ligament traction theory, either the cells of the periodontal ligament or the extracellular collagen provides the force for tooth movement. The fibroblasts of the periodontal ligament possess contractile filaments and are in contact with one another to permit summation of contractile forces, and exhibits fibronexuses by which force can be transmitted to the collagen fiber bundle. The angulation of the periodontal ligament fiber bundles is essential for tooth movement, and this orientation of the collagen fiber bundle is believed to be established by the developing root, which creates flow lines in the gel-like dental follicle. Thus, according to this ligament traction theory, the tooth eruption could be brought about by a combination of events involving a force initiated in the fibroblast of the periodontal ligament, and this force is transmitted to the extracellular component via fibronexuses and to the collagen fiber bundles, which is aligned in an appropriate inclination brought about by root formation, bringing about tooth movement. So this is the summary of periodontal ligament traction theory. So the tooth movement could be brought about by a combination of events involving the force initiated by the periodontal ligament fibroblast, and this force is transmitted to the extracellular component via fibronexuses, and the collagen fiber bundles are aligned in an appropriate inclination, and this alignment is brought about by the root formation, and all these events bringing about tooth movement for eruption. So they have proposed the existence of myofibroblasts. They are the modulated fibroblasts which possess contractile mechanism and also has some structural features and similar pharmacological responses to smooth muscle cells. That's why it is known as myofibroblast. But there is no convincing evidence, it has been reported, to confirm or deny the existence of myofibroblasts in perdonal ligament. No evidence that the fibroblasts exert force that is sufficient to move the tooth under normal physiological conditions. And also, fibroblasts in vivo experiments do not exhibit the features of a migratory cell or that of a myofibroblast. The role of periodontal ligament in tooth eruption cannot be denied, since the ankylosed tooth, where the tooth root is fused with the alveolar bone, and also the dental implants, they do not show any occlusal or even mesial movements. A recent hypothesis regarding the tooth eruption is that it occurs due to an innervation provoked pressure in the apical part of the tooth, which requires continuous adaptation from the periodontal ligament and active movement of the crown follicle, destroying the overlying bone tissue. So this is the recent concept regarding tooth eruption. So it's a hypothesis. It states that eruption occurs due to an innervation provoked pressure in the apical part of the tooth, which requires continuous adaptation from the periodontal ligament and active movement of the crown follicle, destroying overlying bone tissue. Next is the pulp growth theory. So it is actually an extension of the vascular pressure theory. It states that growth or constriction of the pulp generates propulsive force by growth of the dendine, growth of the pulp, and hydraulic effects within the pulp vasculature. But evidence against this theory is, again, the eruption of pulpectomized tooth. It is happening. Next is neuromuscular theory of tooth eruption. It's also known as the unification theory of tooth eruption. It states that synchronized forces of the orofacial musculature controlled by the central nervous system are responsible for active movement of a tooth. These forces also prepare the pathway for the molecular events which play a role in tooth movement. So it is a recent concept, the theory which is known as the neuromuscular theory of tooth eruption, also known as the unification theory. It states that synchronized forces of the orofacial musculature controlled by the CNS are responsible for active movement of a tooth. Next is the dental follicle theory. Dental follicle actually induces bone resorption above the developing crown and bone apposition below it. This results in the formation of an eruptive path through which the tooth moves passively. So here an asymptomatic bone remodeling actually enables the tooth eruption. So that is what is meant by the dental follicle theory. Experimental removal of dental follicle results in a failure of tooth eruption. So when follicle was preserved and the tooth was removed and replaced with some metal replica, the eruption has occurred normally. So it states the importance of dental follicle in the process of tooth eruption. Dental follicle, reduced enamel epithelium, stellate reticulum, and alveolar bone regulate eruption by inductive signals. So you can see the coronal aspect of dental follicle actually regulates bone resorption. So that is being demonstrated by higher expression of bone resorbing genes, and the apical aspect regulates bone formation, which is also demonstrated through the higher expression of bone morphogenic protein 2 gene. So this theory also states that tooth eruption is regulated by the paracrine signaling of the dental follicle. So interactions between the dental follicle, the reduced enamel epithelium and the stellate reticulum lead to the recruitment of monocytes to the dental follicle, which ultimately results in bone desorption through osteoclasts. Reduced enamel epithelium also secretes proteases, enzymes that aid in creating an eruptive pathway through enzymatic degradation of collagen. So from all the above mentioned theories, it can be constructed that tooth eruption is not associated with a single factor. So eruptive movement is a multifactorial one, like vascular pressure at the apex along with contractile force generated by the dental follicle. They all play an important part, and also the bone formation and resorption also facilitating the process of tooth eruption. So next is regarding certain clinical considerations related to tooth eruption. First one is premature eruption. So it occurs in systemic diseases like hyperthyroidism, hypophosphatasia, acute lymphocytic leukemia, cyclic neutropenia, cherubism, etc. So premature eruption of permanent teeth could also be due to premature loss of primary teeth if it occurs within 1 year before the date of eruption. If extraction is done at very young age, the eruption of permanent teeth is actually delayed. Next is delayed eruption. It could be due to either local or systemic factors. The local factors are a retained deciduous tooth, a thick fibrous tissue or bone or the erupting tooth, a lack of space, a traumatic injury to the periodontal ligament, a cyst or a neoplasm or supernumerary tooth in the eruption paths. These are the local factors. And the systemic factors include deficiency of growth hormone, deficiency of thyroid hormone, parathyroid hormone, nutritional status of the individual, genetic factors, osteopetrosis, syndromes like Albright syndrome, Hurley syndrome, and cleidocranial dysplasia. Failure of tooth eruption. Primary failure of eruption and mechanical failure of eruption is there. The primary failure of eruption may be caused by genetic factors. Here, the tooth may emerge into the oral cavity and fail to reach the occlusal plane, mostly happening in case of posterior teeth. Whereas the mechanical failure of eruption may be caused by a physical barrier. Example, a retained deciduous tooth or a supernumerary tooth or presence of odentome or intraosseous cyst or tumors. The ankylosed tooth, where the root is fused with the alveolar bone, doesn't have inherent eruptive force and they also fail to erupt. Supraeruption. It is also known as hypereruption, which occurs when the opposing tooth is lost. The occlusal surface of the involved tooth crosses the occlusal plane. However, the crown height is not increased. So the supraeruption is mostly occurring when the antagonistic tooth or the opposing tooth is lost and there is no increase in size of the tooth, but the tooth is crossing the occlusal plane. Next is regarding passive eruption. So it is characterized by apical migration of the dentogingival junction and exposure of more amount of crown and sometimes even a portion of root. This gives the apparent appearance of tooth eruption even though there is no active occlusal movement of the tooth. So that is meant by passive eruption. Ectopic eruption. The eruption of tooth away from its destined location. The reasons include a wrong eruption path, lack of space due to smaller jaw size, a premature loss of deciduous teeth, the presence of odentome or supernumerary tooth. Impacted and embedded tooth. Impacted teeth are unerupted or sometimes partially erupted tooth due to a lack of space or by a tooth block. Embedded teeth are also unerupted, but they actually lack the eruptive force. There is no mechanical block or obstruction, but the tooth lacks the eruptive force. That is what is meant by embedded tooth. Submerged tooth. These are ankylosed deciduous teeth, especially the mandibular second molar. They exhibit the resorption of root and ankylosis to the alveolar bone, and thereby preventing the eruption of succedaneous premolar. So the most commonly submerged tooth is the primary mandibular second molar. Natal and neonatal teeth. Natal teeth are those teeth that are present at the time of birth. Neonatal teeth are those teeth that erupt within 30 days. Most commonly involved tooth is the mandibular central incisor, and they may cause problems during feeding, ulceration of the tongue of the neonate, and these teeth also exhibit certain structural abnormalities like atubular dentin, aprismatic enamel, and absence of cementum. There is a terminology known as pre-deciduous teeth. It's actually a white hornified epithelial structure, may be present on the gingiva over the alveolar ridge at the time of birth, which can easily be removed. So it has to be differentiated with natal tooth. So here we conclude our discussion on the topic of tooth eruption. So we have discussed regarding the definition of eruption, the pattern of tooth movement, and various theories of tooth eruption. The pattern of tooth movement, you should remember the three phases, that is the pre-eruptive, eruptive, and post-eruptive movements. Pre-eruptive movement is happening mostly within the jaw bones, whereas the eruptive phase is having an intraosseous and extraosseous component. And the post-eruptive movement is happening in three ways, that is one, to accommodate along with the increase in size of the jawbone, and also in order to compensate for the incisal or occlusal and the proximal tooth wear. And theories of eruption we have discussed regarding the bone remodeling theory, the root growth theory, the vascular pressure theory, and the well accepted ligament traction theory, and some of the recent theories like pulp growth theory, the neuromuscular theory, and the dental follicle theory. Once again, I extend my sincere thanks to Team Annur, especially Dr. Deepu George, for inviting me to this wonderful event of Exam Focus 2024. And I wish all the very best for all students who are going to write the university exams. Thank you.